We are also live on YouTube.
Yes. Yeah. 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 So, but it is there are not many, but so yeah. Yeah. So Charlotte.
Yeah, I'll broadcast and let people come in.
Okay, and I will also check whether there are people late registering,
Okay.
and I will take care about that.
Okay.
Mhm. Mhm. So let's wait for a couple of minutes before we start. So I will start with the introduction, okay? And so people will then join in. So good afternoon and welcome to the 6th MDPI webinar on COVID-19. The topic today is a survey on symptoms, signs, protective measures, level of awareness and perception regarding COVID-19 outbreak among dentists. We have the great honor and privilege to present two highly ranked experts for this topic. Maria Grazia Caccetti, she is an associate professor at the Dental School of the University of Milan, Italy, Department of Biomedical, Surgical and Dental Sciences, and the head of the Pediatric Dentistry Specialization course at the same university. She obtained a degree in dentistry in 1991 with honors and a PhD in preventive dentistry in 1996. Dr. Caccetti is a member of the Italian WHO Collaborating Center for Epidemiology and Community Dentistry. Her research interests are largely direct towards preventive dentistry, community dentistry, pediatric dentistry, cardiology, and oral epidemiology. And as a second speaker today, we have Guglielmo Campos. He is Professor for Preventive Dentistry and Oral Epidemiology at the University of Bern. And he has completed his training at the dental school of the University of Sassari in Italy and has been Associate Professor for Community Dentistry, Cardiology, and Pediatric Dentistry at the University of Sassari since 2014. He is also coordinator of the Italian WHO Collaborating Center for Epidemiology and Community Dentistry. So the house rules today, so please post your question in the question and answer box. And if you want, you can raise your hand to enter the live debate at the end of both presentations. So if you are a researcher and interested to submit a paper in one of our supporting journals, International Journal of Environmental Research and Public Health, please get in touch with us. And now I would like to pass the virtual floor to Maria Grazia. Please go ahead. Thank you very much.
Thank you very much to you. I share the screen. Okay. Can you see my screen? I don't hear now. Okay, very well. First of all, good morning, everybody. Thank you to invite me to this webinar. My speech will focus on the risk of COVID-19 infection in the dental setting. SARS coronavirus 2, the virus that caused COVID-19, is primarily spread through respiratory droplets when an infected person coughs, sneezes, or talks. The two main routes known for the transmission of the virus include direct transmission through inhalation of droplets and contact transmission through contact with contaminated surfaces. Airborne transmission from person to person over long distance is unlikely. Clinical manifestation usually start less than a week. Fever, cough, nasal congestion, fatigue, shortness of breath. Asymptomatic infection are described, especially among young children. People infected with SARS coronavirus 2 do not commonly experience severe symptoms, even though they might. Overall, reported case fatality rates vary from 1% to more than 7%, mainly due to bilateral pneumonia. In a case series described the clinical characteristic of 138 hospitalized patients with COVID-19, 57 patients were presumed to have been infected inside the hospital, of whom 17 patients were already hospitalized for other reasons, while 40 were healthcare professionals. Of the infected healthcare professionals, 31 work on general wards, 7 in the emergency department, and 2 in the intensive care units. According to the Italian Federation of Physicians, Surgeons and Dentists, the number of deceased physicians up to June 21st amounted to 169. Among these, 55 were general practitioners, category the most exposure to the virus, and 15 were dentists, second most exposure category. The practice of dentistry involves several activities that might increase the risk of virus transmission and diffusion. Both routes of transmission, direct and indirect, are possible. The use of rotary dental instruments such as species and ultrasonic scalers and air water syringes and surgical instruments may represent potential devices to spread the virus. An example of virus diffusion in medical office was that of the measles virus that spread through ventilation system to multiple people. The source patient was a 12-year-old boy who was coughing. Of the 7 people who had secondary cases of measles that were associated with him, 3 were never in direct contact with a source patient, and 1 entered in the office 1 hour after he had left. In the dental setting, the virus transmission may occur through 4 major routes. 1, direct exposure to respiratory secretion containing droplets, blood, saliva, or other patient material. Indirect contact with contaminated surfaces or instruments, inhalation of suspending airborne viruses, and mucosal, nasal, oral, conjunctival contact with infection containing droplets and aerosol that are propelled by coughing and talking without a mask. Splatter and aerosol produced by the dental species during routine treatment critically contribute in increasing this risk. Splatter are air suspension of liquid or solid particle having a particle size of approximately 100 micrometers or more, while aerosol particles have a smaller diameter that of about 50 micrometers. Splatter are too large to be inhaled, but can contaminate the skin, eye, air, in addition to the whole dental environment. Aerosols are small enough to stay airborne for a long time and then settle down on environmental surfaces and enter in the respiratory tract. The stability of SARS coronavirus 2 in aerosol and on various surfaces was investigated in experimental conditions, showing that the airborne transmission viruses is plausible since the virus can remain viable and infectious up to 3 hours in aerosol and up to 72 hours on surfaces. This situation called for dental care protocol in order to reduce the risk of infection. The oral cavity constitutes the high source of the infective microorganism, derived from dental plaque, both supragingival and in the periodontal pocket. It should not, however, be overlooked that the mouth is a part of the oronasal pharynx. As a part of this complex, the mouth harbors bacteria and viruses from the nose, throat, and respiratory tract. These features contribute to make the dentist's job to be considered the most unhealthy job in America. The Occupational Safety and Health Administration has divided job tasks into 4 risk categories, from very high to lower risk. Very high exposure risk jobs are those with high potential for exposure as healthcare worker performing aerosol generating procedure, that's intubation or dental procedure, in patients with known or suspected COVID-19 infection. The use of rubber dam will significantly minimize the production of saliva and blood-contaminated aerosol splatter, particularly in cases when high-speed handpieces and dental ultrasonic devices are used. Nevertheless, the use of a rubber dam was associated with more bacteria colony-forming units spread not from the inside of the patient mouth, but from the splatter created by water spray hitting the dam and reaching the head of the dentist. Preoperative antimicrobial mouth rinse is recommended to reduce the number of these microorganisms. Reduction in bacterial load using 0.2% of chlorhexidine glygluconate mouthwash is found to be significant in both saliva and aerosol produced by dental device. No study has proven that chlorhexidine mouthwashes are ineffective against the novel coronavirus. Handpieces must be equipped with non-return valves to avoid cross-infection. In a study promoted by the Italian Ministry of Education, Ministry of University and Research, the malfunction of anti-retraction valves was found after 60 days of use in more than 80% of tested devices. During the COVID-19 breakdown, state government and National Dental Association suggest dentists in the region the minimum number of days in which they had to keep the office closed in order to be prudent, however, ensuring emergency care. The American Dental Association report what dental emergencies are: potentially life-threatening, requiring immediate care for stop ongoing bleeding, alleviate severe pain or infection, as well as trauma involving facial bone. Urgent dental cares are also included. They focus on the management of conditions that require immediate attention to relieve severe pain or risk of infection. The use of PPE must be in accordance with the risk of infection that each clinical procedure entails. The main factor to be taken into consideration when choosing the most suitable PPE is if the procedures involve close proximity to the patient oral cavity, but above all, if infected or potentially infected aerosol will be produced. In this table, we can see that the 3 levels of protective measures are recommended. Standard for all dental personnel in the dental office, advanced for dental personnel who work closely with the patient face, and threatened protection to adopt when aerosol generating procedures are needed. When aerosol is generated, different respirators are available. The lack of research on face masks and respirators is reflected in different and sometimes conflicting policy and guidelines. What is certain regarding surgical masks is that they protect the mucosal membranes of the mouth and on the nose from droplets and splatter, but they do not provide complete protection against inhalation of airborne infective agents. The Center for Disease Control and Prevention has suggested dental-specific recommendations to prevent the diffusion of SARS coronavirus 2 in the dental setting. These recommendations underline that in absence of airborne precaution, the risk of the virus transmission during aerosol generating procedure cannot be eliminated. Therefore, a reduction of treatment that can produce droplets or aerosol is recommended. However, the majority of dental treatments are usually carried out with the use of handpieces under water spray. Different current treatments that not include the use of handpieces are available. The so-called non-invasive treatment, mostly carried out on initial caries lesion, and the minimally invasive treatment on more severe caries lesion, both treatments are particularly suitable for children, but they can perform also on adults. In addition to the CDC guideline, different organizations and professional bodies in each country suggest specific recommendations. However, they did not fully match, contributing to confusing and uncertainty in the dental category. These recommendations can be divided in three domains: those to be applied before the patient arrival, those dedicated to the waiting room, and those to be followed in the operative room. Phone contact before the scheduled appointment is a very important moment, not only to perform a first triage regarding symptoms and signs potentially related to SARS-CoV-2, but also to inform the patients regarding all technical and practical aspects during his visit in the dental setting. Among the recommendations for the waiting room, those reported in this slide are the most frequently suggested. Others can be found, including the use of gloves for patients, the use of overshoes for patients, and so on. Now we can see the operative environment. The management of the operative area for dental care should be similar to those where patients affected by infection and highly contagious disease are treated. Only essential tools and personnel can be admitted in order to reduce the risk of direct and cross-infection. If aerosol generating procedures must be performed, precautionary measures have to be taken. First of all, dental professionals should wear an N95 or higher level respirator, as well as air protection, gloves, and gowns. Only essential personnel for patient care and support are admitted. Aerosol generating procedure should ideally take place in an airborne infection isolation room. It is mandatory, do not schedule any other patient until disinfection procedures are carried out and contaminated air is removed from the room. Decontamination of the operative room must be carried out in accordance with the latest recommended procedures. The responsible person undertaking the cleaning with detergent and disinfectant should be familiar with this process and procedures and must wear recommended PPE. The disinfection of all surfaces for 1 minute can be performed using sodium hypochlorite 0.1-0.5%, ethanol 62-71%, or hydrogen peroxide 0.5%. Scarce data is available regarding the topographical distribution of surface contamination in the dental operative environment. And this information is essential to implement protocol for disinfection procedures. The present studies recently accepted for publication in the journal the American Dental Association aim to evaluate the contamination resulting from the use of rotary and vibrating oscillating instruments. Using a biological tracer, the contamination of the dental unit and the operative room resulting from 3 standard dental procedures was quantitatively and topographically assessed. For the first procedure, a class 1 cavity was performed using an air turbine and piece. For the second procedure, a quadrangle hand piece was used inside the previous prepared cavity. And for the third procedure, an ultrasonic scaler was used below the gum line of the vestibular, lingual, and interproximal surfaces of the same prepared tooth. Each procedure lasts 4 minutes. A phantom head was fixed to the chair headrest. A continuous flow of Streptococcus mutans suspension was infused in the mouth of the phantom during all procedures. The presence of a biological tracer was measured in 22 sides of the dental unit and 68 sides of the preventive room. That dentist is myself during the experiment. This is the first graph. The first graph shows the contamination produced by the air turbine and piece. As you can see, different areas of contamination in the operative room are present. The highest contamination area was found more than 1 meter from the phantom mouth, where a high prevalence of splatters was found. A lower contamination level was detected until 3.6 meters from the source of infection, caused primarily by aerosol. And this is a very important finding because it's a very long distance, 3.6 meters. This was the major distance that we have measured the biological tracer. This is the ceiling of the room. As you can see, all the side of the ceilings were reached by the tracer, especially those just over the dental unit in the left part of the ceiling. This is the floor and the walls. In the floor, a high contamination level was found around the dental unit, and a low contamination level was found farther away from the dental chair on the floor and in the walls behind and in front of the chair. Regarding the dental chair, the backrest and a part of the seat presented a high level of contamination, as well as the spittoon. The lamp and the pedal show a lower level of the tracer. A similar pattern of the contamination observed for the air turbine was found for the quadrangle and piece, even if contamination levels were quite lower. The tracer had not reached the portion of the ceiling located at greater distance from the dental units, as you can see in this picture. And here we are the floor and the wall. Even the floor was only partially reached by the tracer. And finally, the dental unit. All parts of the dental chair were highly contaminated, including lamp, pedal, spittoon, and the touchpad control of the assistant. Finally, findings regarding the contamination produced by the ultrasonic scaler. A higher contamination level was detected closer than the infection source, but already at 1.8 meters, the level of contamination was low. Just one side of the ceiling was reached by the tracer, just over the head of the phantom. Even for the scaler, the floor was only partially reached by the tracer. The contamination level around the chair was extremely high. And this is the dental unit. This is the chair in which we can see that only the end of the seat has not reached by the tracer. In conclusion, the findings highlight the high contamination level of the dental unit and surrounding area. Air turbine and space produced the highest level of aerosol that contaminated the interior operative room, reaching the maximum distance of 3.6 meters. The greatest contamination of the dental units, caused mainly by splatter, was found after using the ultrasonic scaler. Quadrangular, end-piece, and ultrasonic scaler produce less aerosol than air turbine. In conclusion, literature findings and those produced by our research group confirm that the risk of infection transmission in the dental environment is high, and precautionary approach is mandatory for the safety of dental personnel and patients during COVID-19 pandemic. PPE and decontamination of both dentists and dental assistants are essential to avoid the infection of dental care workers and avoid cross-infection. But the interior operative area needs to be cleaned and disinfected after aerosol generating procedure. Now I'm finished. I'll leave the word to Professor Campus, who will describe the findings of a recent survey among dentists working in Lombardy, where I am now, region with the highest prevalence of coronavirus cases in Italy. Thank you.
Good afternoon to everyone. Thanks to joining us to this webinar. I will speak about, as Maria Grazia says, an overview for dentistry and public health. As I am professor of public health, I will now present because I have to speak a bit what Maria Grazia says before. So the specific, what about dentists and what dentists have to use. So I really think and I really believe what Maria Grazia says before, that we need as a dentist, because we are a really highly risk to get contaminated by aerosol. And so we really need to do something to know exactly. So in this slide, you can see which are the different levels regarding the CDC, regarding the COVID alert from basic, conditional, and et cetera, which we have a high level and very high level or low level, so which needed to be used during dental procedures. And so we have to know that if we are in a low risk time, like probably if we are talking about Switzerland, or if you are talking from some part of Italy, or if we are talking also some part of Germany or something like that. But we have to still maintain social distance. We need to wearing PPE. We have to use the minimal using, if you have to use, if we have to use tooth polishing, we have to reduce the speed. About that, we have to do tooth isolation, and then if you are using extraoral radiography, it's still maintaining social distance. And if you have to use intraoral radiography, we have to use only with patient without Koger reflex, and also only with adults. If you are doing dental photography, I really think that is not maybe so important, but if you have to use intraoral only in patients with they are not triggering of a cough. Clinical examination, we have not to use the hair siring. And then if you did direct restoration, provisional restoration, and then if we have to cement, crown and bridge, provisional, but we can use for removal prosthodontics more or less all parts in all stages. And then if you have to repair, we have to disinfect them and blah, blah, blah. And this on the right regarding if we are in a high risk period of the pandemic. So for example, we cannot have oral hygiene instruction, we cannot have oral extraoral radiography, probably we cannot use et cetera, and other things. So I really believe, we really believe that we as dentists, we have to play a very important role against COVID, because our profession and our patient needs to be kept safe as long as possible. So what we have done, so you know that Italy have quite a very impressive progression of the disease, especially in the north of Italy. And so during the week before Easter, I, Maria Grazia, and other two guys that work with us, so we started discussing and we wrote a questionnaire about how dentists are feeling and how dentists are decide to treat patients during the COVID pandemic and how they decide to protect them. So we built up the questionnaire and then we also pre-tested them. And then we mailed it using an online survey. In this case, we use SurveyMonkey. And we decided to go only relating to a part specific on North Italy. This is the Lombardy, is the area where we have the highest number of cases of COVID-19. And still today, if you are looking to the data regarding Italy, you can see the 80%, 75% of new cases, and the number are really reduced. It's only relating in this part. And you can see on the left that the paper was accepted by the International Journal of Environmental Research and Public Health, and it was published. Just to do an example of the data that we get. So we divide the Lombardy in 3 different areas. We divide the Milan area because it's the area where is the highest number of population. And then we divide the high prevalence area and the low prevalence area, because one of the characteristics of this disease that the prevalence varies a lot in different areas, even just in one region that is not so big like Lombardy. So it's not small, but it's not so big. So there are areas in Lombardy where the prevalence of the disease is similar to other parts of the country, but there are areas where the prevalence is very, very high. And you can see one of the questions that we ask to the dentist, if they have suffered at least one or more than one of the symptoms that are related to COVID. Also, from all the people that replied to the questionnaire, that were more than 4,000, we have that 42 were positive to COVID, really positive. And you can see that the prevalence of more than 3 symptoms, you know that the most common symptoms are cough, are fever, are respiratory problems or something like that. And you can see the difference regarding the Milan area, the low prevalence area, and the high prevalence area. 10% of the people that reply to the questionnaire, they have at least 3 or more symptoms relating to COVID-19. So it's quite impressive. So this on the right, you can see that was the questionnaire. It's a very simple questionnaire. We can say that the questionnaire is divided in 4 main items or 4 main domains. So there was the first domain we can call like vital statistics, like gender, the age, and where they are living and where they are working. We are using the ZIP code, sorry. And also we are asking if they are working as a private dentist or if they are working as a national health system partially or full time. I don't know how familiar you are about the situation in Italy, but usually 90% of the dentists are working, even more, are working as a private. And then we have, we can say, a domain relating if they are still working, if they have symptoms or not, as I told you before, as I showed you before, and then if there is working on a national system, if they are still working, if they're still working as usual, or just doing only emergency, as Maria Grazia has explained to you, or they are just stop all activity. And then if they have a limited, their professional activity, when? And these are the dates that for Italians are very important, because the 21st of February was the first case that was really diagnosed with COVID in Italy. And then it was the period where the number of cases was increasing and increasing. And then after the 14th of March, when the government decided for a lockdown of all the country. And then the other domain was what kind of measure you have used before the patient enter in your operation room. So if they are doing nothing, if they are using phone triage, if they decide to dilute the appointment, just not to saturate the waiting room, just they refuse to treat older people, or etc., etc. If the temperature of the people arriving to the cabinet was measured or not, and blah, blah, blah. And then the third domain was about what they are using as a protection, as PPE for the dentist. So if they're using only a surgical mask, or if they are using a facial filters like FFP2 or FFP3, if they're using a disposable headset, a sterile microfiber, and TNT dissolvable gown, etc., etc., if they're using normal gloves or sterile gloves, and blah, blah. And then the last items was relating to the attitude and also to the feeling. What are the feeling? What are you feeling about the disease? Just to make an example, one question was relating how you feel about your profession. Do you think that your profession is a high risk, a normal risk, or even a risk, low risk, like going to go shopping for grocery or something like that? And you can see here the symptoms that were more related to COVID-19. And you can see the difference regarding the three areas. Let's take a look again to the high prevalence area, where more or less 15, we can say, 15% of the dentists means that they have fever, cough, or fatigue, or sense of fatigue, and etc., etc. And then we have the distribution by age and gender, and also here the distribution relating to the number of symptoms, one or more symptoms in the different area of the country, or sorry, of the region. And here we can see the replies. And you can see that, for example, before the patient to arrival, 82% of the dentist says that they do the phone triage, 86% do a diluted the appointment just not to saturate the waiting room, and then in the waiting room they decide to do the infection of push button, the ATM or point of sale machine, the chairs several times a day, and also to washing the patient hand 78%, etc., etc. And then in the operation room, you can see that there were several questions that have quite strange in a way, but we decided to put, we call it like a trick question, just to see if the person that are applying to the questionnaire, if they have some kind of attention or not. So they said yes, 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 yes. So some questions seems quite strange. But you can see that if we are talking about chlorhexidine, as Maria Grazia showed you before, more than 0.5% they said they are using chlorhexidine, even if we are not sure yet that it works or not. And then, of course, the disinfection of surface, washing operator hands, removal of oral disposable protection, etc., was quite high. And then here in this slide, you can see what kind of measure were stratified by the area. And you can see now that some strange data arrive, because you can see that not always in the high prevalence area or in the low prevalence area, there is a difference. So since, for example, the delay of the appointment was higher in the Milan area, where they have more or less a medium number of cases respect from the low areas and the high areas, because 90%, but only 84.47% in the high prevalence area. And it's still the same regarding the disinfection of push button, point of sale, chairs, etc., that was higher in the Milan area, in the low prevalence area. This is quite, in a way, typical. We are doing at the moment also a survey about dental hygienists, and it's just not published, it's not really analyzed yet, but the result seems that the age of the dental hygienist is more important relating to the prevention measure than the area where they are living and regarding the prevalence of COVID or something like that. And these are the personal protective equipment. And you can see the difference, and these are in the different area. And again, it's possible to see that there are something strange because the risk perception is quite strange in a way. Do you believe that infection is a risk for the dentist? Only 61% in the high prevalence believe on that. 66 in the Milan area, 64 in the low prevalence area. And also how sure you are that you can avoid becoming infected with SARS-CoV-2 during work. And you see that it was quite good, but was not a difference at all between the 3 areas. And then this is more or less the, no, sorry. Okay. And then after that, we start discussing, I started discussing with Maria Grazia and also with my colleagues here in Bern, what about this questionnaire? How other dentists in other countries believe on that? And so we decide to go international to something like that. So to use the same question as a global survey on symptom and sign, protective measure, level awareness and perception regarding COVID-19 in dentistry. And so we decided to write a protocol and asking to several dentists all over the world. Usually we collected some friends or other people to see what are. So the research question are 3. So what is the prevalence in the symptom sign relating to the pandemic in dentistry worldwide and in different countries? What is the level of preparedness regarding protective measures in PPE to reduce the risk of viral transmission? What is the level of awareness and risk perception of dentists regarding COVID-19? Because we really believe that it's of extreme importance to have this data and then to try to writing down a guideline that will be accepted in different countries, and also because we have to just knock to the door of our politician or our Minister of Health and saying, okay, did you see that dentists are the most vulnerable population regarding the transmission of COVID? We have to do something. So we need the support of the Minister of Health and the health authorities to do that. We cannot do by ourselves. Okay, and then in this slide, you can see just is the Gantt graph about the study. So we have to spend more or less 1 month planning, and then the questionnaire, and then we have decided to standardize. And then as we are doing in different countries, you can see in the next slide, the different countries, we have to translate the questionnaire is just relating to research things in the different language and then check if the translation is okay. So it takes some time. And then will be the survey, the data analysis, and then the reporting at the end. At the moment, 3 different countries have completed the questionnaire. One is Spain, the other one is Germany, and the other one is Italy. UK is almost completed, and the other countries are at different levels. And you can see in this graph, you can see that we are doing this study in the US, in almost all countries in South America. You know that now South America is just in the middle of the problem of the tragedy regarding COVID, like US. And then we have more or less several countries of Europe, like Spain, France, Switzerland, Germany, Belgium, Netherlands, UK, and blah, blah, blah. Also a lot of Balkan countries, the Russian Federation, China, India, Australia, Malaysia, and few, not so much. I'm so sorry for that, African countries. Okay, just to conclude, what for us this project is so important, because the result of this project will help to define which is the best strategy to organize the dental workforce, how we can deal if there will be a second wave, or in the meantime, until a vaccine or a real therapy is possible. And also, we will probably, we hope not, but we will probably help if other kind of virus pandemic or virus morbidity will arrive in the future. And also because we need to be able to care for all our patients, but we need to minimizing or even complete destroy the risk for staff, and so maintaining a workforce that is healthy. I finish. Thank you very much.
Thank you very much, Professor Campos. The Q&A session is now open. So we already have 2 questions here, and I think it was for Professor Caggetti.
Okay.
So the first one was, do we have COVID-19 specific consent form for dental treatment and insurance? Perhaps both of you.
Yes, in Italy, I can see what happened in Italy. In Italy, then Ministry of Health have prepared a consent for a patient of dentist. In this consent, the patient had to assess that he had filled all questionnaire regarding symptom and sign related to COVID-19. And he had to assess, to declare that he have received all indication, all suggestion to adopt during the visit to in the dental office. It is in Italian. If you want to, we can send them. We can translate in English and send. It's very, very short, and I think it's a good strategies for legal reason.
Okay, thank you. Then we have Juliana Moratti who asks, do you have any data on contamination and or death of patients due to cross-contamination during dental treatment?
Rispondi tu, Guglielmo?
Okay, I'm trying to, when I read this question, I'm just looking on PubMed because I have to confess to Juliana that I have no idea. I think that the death is quite low because, okay, but there is several data about contamination regarding to cross-containing during dental setting. I remember when the AIDS problem was, the AIDS epidemic was quite important. There were some cases relating to the contamination and also the infection during dental treatment about AIDS, but I don't know exactly about dentistry and death.
I think that no data are available regarding infection or death during dental treatment for COVID-19.
No way, no one.
But
this I'm sure.
It's very difficult because I speak for my my situation. Italy and Milan and Lombardy were a very, very high number of COVID are reported, because when COVID spread was so rapid, so immediately, that in a few days all dental office closed. So it's very difficult to know if the infected people become infected inside the dental office, inside the supermarket, inside at home. It's at school. It's very difficult. Until now, I think no one have tried to understand where exactly the infection was developed. So I think that no data are available at the moment regarding COVID-19 and dental infection, dental setting.
Yeah. If you go to PubMed, you wrote death cross-contamination dental treatment, it's possible to find very few papers, and there is some cases, I think that it was 3 cases confirmed about the Creutzfeldt-Jakob disease during dental treatment, and 2 cases, but not due to that, not brings to death regarding AIDS. And that's it.
Okay. We have another question here. Is there data about dentists themselves getting infected?
Yeah, we have data from Italy that in our sample, 42 dentists get infected during from the 4,500 and something that reply, that get the infection. But of course, as Maria Grazia told just 3 minutes ago, we don't know exactly if they get infected during dental treatment or just, for example, go shopping or whatever. You know that as any disease that go by airborne, so it's very difficult to just isolate something like that.
And in my presentation, I told that 15 Italian dentists are deaf for COVID-19, but we don't know where the infection was developed. Perhaps during work, but it's not possible to know exactly.
Okay, then Mark Moss asked, what are your thoughts about testing of dental staff for COVID-19 infections? For example, how frequent should testing be done? Do we wait for symptoms and then test, or test routinely regardless of symptoms?
You want to reply with you have a personal experience, Maria Grazia?
No.
Rispondo io. Okay, the big issue that the testing is still have a quite high number of false positive or false negative, because probably the best test is still the use of tampon, but is relating to the capacity of the personnel this is doing, because they are removing some, we can say, plaque or material alba from the air, etc., but we are not sure if they are touching all the area or just some part. But this is quite good as a result. The other tests, like the serological, there are several tests. They have a very high false positive or negative. So in a way, I really think that if a good test is present, I think that all dental staff have to do that. Okay, I'm very strict sometimes. For me, if the test is good, I really believe that for dental personnel it's mandatory to do a test. But until the test is not reliable, the reliability of the test is quite low. So it means that probably a person has to do several tests. So even if you said, okay, I'm negative, it's not negative, because we have to do again after 2 weeks, and the same if it's positive or something like that. Also because from serological, there are just 2 main families. So the IgG means that you have a history of COVID-19 that probably you have in the past, and at the moment you have the antibody or the antibodies. But if the IgM means that you have the disease in the active phase. But even these 2 differences is not really clear at the moment.
Right. Oh, we've got quite a few more questions. So Emilia has asked, are any schools in Brazil participating in the COVID-19 global survey?
Okay, we work like that. We found a team in each country that they want to do that, and each team have a leader. For example, for Brazil is Professor Daniela Raggio, right, Maria Grazia?
Yes,
She's
Raggio,
from the
yes.
University of São Paulo in Brazil, and she have her team. There are more than 10, because you know that Brazil is very, very high, very important, have a lot of population, also because one of the protocol regulation that each team have to reach a range between 5–20% of all the dentists in the country. That means there are quite a lot. So I think that if Emilio wants to collaborate or just to work, he can contact her or can contact me, and then I put in contact with Professor Raggio.
Okay. Actually, there are 2 other questions about participating. Jenny wants to know, are you still looking for countries who have not yet participated?
Yes, okay. We have to put the date, as you can see in the Gantt chart. So we accept country until the 8th of July. After that, is not possible to accept because we have to finish. Because as I told during my presentation, there are 3 countries that they are finished. They want to analyze the data. So until the 8th of July is possible. So if other countries want to participate, they have to contact me.
Okay, and someone who wants to know if still to do with participating, do you need any volunteers?
Yes, of course.
And
all the different countries have to decide in which way they want to do. There are, okay, for example, we use it, SurveyMonkey. For example, in Spain, they decide to use Google Forms. In UK, they wanted to contact the dentist, sending to them using social media like Facebook, WhatsApp, or whatever. Other countries are using RedCap, so it will be online. So usually it's like this, the list of the dentists will put just in one folder, and then will be, how we can say, randomly chosen, or they will receive all of that using email invitation to the survey. Usually the survey is open between 7 and 10 days. It depends on the country and how familiar they are with internet, etc., etc. To make you an example, in India, we have decided to go for 10 days because there are several areas where the internet connection is not so good. But for example, in UK, it's just 7 days, in Spain, 7 days, or something like that. So the link will be open for 7 days, and then the link will not open again.
Okay. Maybe if you have the link, I could post it on our webpage and people can access it.
No, it's not possible because the link, it will be in English, but each country have to do it a different language just to do as simple as possible. So one of the part of the job, just make an example from Brazil, we have to translate in Portuguese and then test it and then translate back in English. And then if it's okay, go online. That's the reason that not all the countries go online together.
Okay. So the easiest would be that they contact you?
Yeah, absolutely.
Okay, no problem. So then we have quite a few more questions. Saeed would like to know, he wants to work on COVID-19 by using bioinformatics techniques, but he needs data and guidelines. He has a lot of bioinformatic techniques related to drug design and proteomics study. I guess that's how you pronounce it.
It's a very complicated question, to tell you the truth. But I know that, for example, bioinformatics is very important. It was a paper that was published this Monday on Science relating that a drug that was just by bioinformatics decided to have the potentially to be used as treatment regarding COVID. But for our profession, I don't know exactly how bioinformatics can be of help. Even if probably it will be of help regarding the diagnosis, because of course, if you have the antibodies in the blood, you also have in the salivary. So probably in the future will be easier to do the detection and diagnosis just with a saliva sample that costs nothing, is not a problem, etc., etc. Like is doing regarding the Helicobacter pylori disease or something like that. I know there are some research group.
Guglielmo, saliva test is already available.
Yeah.
Because we are tested in Milan.
Yeah, exactly. I was just to say that. But still, there is no scientific evidence about the reliability of that.
Okay. Then Quart, I think that's how you pronounce his name, would like to know if you need volunteers, then how can we connect to the main team to coordinate with them? Okay,
if the person contacted me, I don't know in which country he or she, because I don't know if it's a she or he, sorry for that. And then I will put in contact with the local organizer of that.
Okay. Then Dr. Abdul Kader Mowawala, I'm really sorry if I'm pronouncing it wrong, would like to know if you have any data on psychological evaluation of dentists working during the COVID-19 pandemic, such as stress level, etc.
We have no data, but I really think that is of extreme interest of that, because I really think that all of us that have just to live during the lockdown, we have some kind of psychological stress. I can imagine the psychological stress of people that have to work in health sector during the COVID or something like that. I really think that is a very good question, but at the moment we don't have. Sorry.
But papers are available about this topic, both about dental hygienists and dentists. Not from our research group, but
there are something available.
Yeah.
Okay. Then Zara would like to know, what about measurements which can be taken within the dentist's clinic, additionally to PPE, especially mitigating the viral load in this indoor environment seems to be important?
I think that it's very important to do that. But at the moment, there is no really scientific evidence, because it's the paper that was accepted by Maria Grazia, Professor Brambilla, and others from Milan, relating to, that was accepted to JADA. But it's very, very important, because how to mitigate, how to reduce the viral number, the contamination, how to do fast. Because especially if someone has to work as a private practice, if you have to wait 2 hours before to use the dental chairs, means there is a lot of problems for the person that own the clinic of the private cabinet. At the moment, there was proposed something like to use the ozone, but the problem is that it's a very effective to reduce, but it means that you cannot use the room for at least 2 hours, so it's too much. The other proposal was to use vapor, something like that, like they are using in the street when they want to sanificate or something like that. But still, there is no really scientific evidence how to reduce it.
Okay. Maria Grazia, would you like to answer? Or?
Yes, I think that a possible is a very big aspirator has been... Cappa aspirante, come si dice?
Yeah. So to use some kind of a scavenger just to change the area, etc., etc.
Yeah, but just on the head of the patients, so you can work under this big aspirator. So everything go inside this machine, and the airborne is quite preserved from infection, from diffusion of virus and bacteria.
Yeah, the only thing that you have to think how difficult it is. Also, we have to clean in a very good how we can say, the filter of the scavenger machine or something like that.
Okay, and that is the end of the questions. There are many people who have expressed interest in volunteering. So if you don't mind, I will put your email addresses
Yes, absolutely.
on our webpage, and they can just write to you.
They can just write to me.
Okay.
I'm just looking because, for example, there are some people from Pakistan, and the Pakistan, we have just a team in Pakistan. So why not?
Okay.
Guglielmo, you can write your email address on the chat now. If
No, but Charlotte says that she will put on the web page. Yeah.
Okay.
And people will see it there and write to you.
Okay.
Okay, thank you very much.
Okay.
So
Okay.
Q&A session is over.
Okay.
So thank you very much, and
Thank
it was
you.
a great experience, and
Thank
we
you.
keep in touch. And
Absolutely.
again, also for the participants, if you would like to join our virtual World Sustainability Forum, we will send you the information by mail. Thank you very much. Have a nice day, and see you soon.
I
Thank you.
really hope to see you soon. Okay.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye-bye.
Bye.
Okay. You press. Oh, I have to.
You